LMH site that it is National Doctors Day. So Dr. Huston, I hope that you're not missing some sort of Doctors Day celebration at the office to do this, but happy Doctors Day to you. I didn't know Doctors Day existed until just this morning. But I'd like to tell you a little bit about Dr. James Huston, as much as I know. I know he's a Lawrence boy. He went to Lawrence High, graduated from Lawrence High, and then did his undergrad here at KU, and then went to KU Med and got his medical degree. So he is, we are your people and you are our people. He is also a hip and knee care specialist. So we are really your people, Dr. Huston. So we are anxious to hear your presentation. And with that, I'll just ask you to take it away. Thank you.
Thank you. So appreciate everybody logging in to join us today, and feel free to submit any questions either through the chat or raise your hand, and I'm happy to hit those as we go along, and then certainly we'll have some time at the end to address those. But let me pull back up my presentation. So we're mainly focusing on aging bones or osteoporosis, but in order to talk about that, we kind of need to talk about bones in general and how they work, how they're maintained, and how that process changes in order to develop osteoporosis or similar issues, and then how we identify that, who should be interested in being evaluated, and then how do we go about treating that, and how can we potentially prevent it. So without further ado, maybe. See if I can get it to advance. There we go. So just to start with discussing normal bone anatomy and physiology, bones, most people sort of think of bones as just kind of a tree trunk, like a log that's just there and hard, and you stand on it and move around with it. But really, bones are pretty complex structures. The outer portion of the bone, the ring around the outer portion, is called the cortex. And it is a very dense, hard area. But the majority of the actual volume or surface area of the bone, or inner area, I should say, is spongy. It's kind of a matrix of tissue that actually has a lot more going on within it. There's blood production, and there's a system of blood vessels within the bone, as well as around the outside of the bone. And that bone is much softer, and has, when you're younger, a much denser matrix of that spongy bone. As osteoporosis develops, and generally as people age, that matrix of bone on the inside of the bone becomes more porous. That's where the word osteoporosis comes from. So you have more of that empty space and less of the structure, the scaffolding that's holding the bone together. So it becomes weaker by nature. That bone actually does expand some, and the outer cortex does become thinner. If you look there on the left, shows a thicker rim of cortical bone compared to osteoporosis, which has a much thinner and less solid cortical bone. So it's not hard to imagine that the bone on the left would be much more resistant to breaking if somebody fell down or had an injury compared to the bone on the right. And what we find is that that's very true. Above the age of 50, 1/3 of females and 1/5 of males have a fragility fracture or a low energy fracture that would not otherwise result in a fracture. So it's a very common and widespread problem. The most common anatomic locations for those fractures are the spine, which is typically a compression fracture. Those can be traumatic from a fall, or it can be something that people really don't even know happens until they have some pain and x-rays show that one of the vertebrae in the back has actually just compressed or gotten smaller. In the hip is another one of the most common locations. And then the third very frequent location is in the wrist or distal radius. There are certainly many other locations where you can have a fracture with low energy injury, and that those fractures are deemed a low energy or a fragility fracture, but these are the most common areas. So these are just some x-rays showing what that might look like. Person falls on an outstretched hand, all of the weight and impact goes through that wrist, typically with the hand kind of the wrist extended, bending back. And that results in this pattern where the bone kind of impacts, bends back, and that break can even go into the joint and have instability in the actual wrist joint. Sometimes these are able to be treated with a cast or a splint. Sometimes they require surgery, such as what you see on the right with a plate and screws to hold the bone in a more normal alignment and allow them to heal. As we mentioned, the hip is another common location. This is in the middle x-ray. There is what we call an intertrochanteric fracture. It's a very common pattern of hip fracture where the hip or the femur bone breaks right at the top of the long part of the bone, the shaft, and right where it transitions into the femoral neck between the greater trochanter and the lesser trochanter. So intertrochanteric fracture. Those are typically treated almost universally with surgery, and most commonly a surgery as illustrated here, where a rod goes down inside the bone that has a compression screw that locks into it. The bone is pulled out to normal alignment through traction and rotation, and then that compression screw is locked into the rod and holds the bone in that normal alignment in order to allow it to heal. This is another very common injury and a fairly devastating injury for a lot of people. It's very high stress on the general metabolism and the body as a whole, the person as a whole, and can take a real toll on a lot of people in terms of trying to get back to activity and normal life. But benefit of surgery here is that this allows a person to put full weight on it safely without worrying about that fracture collapsing or shifting. Similar fracture, but different, slightly different location within the hip is what we call a femoral neck fracture. Not a whole lot different mechanism, still falling and injuring that hip. But if that bone breaks just a little bit farther up towards the hip joint itself, then it's less able to heal because it's inside the hip joint. And it is better treated with a hip replacement, whether that be a partial or a total hip replacement, which is what's pictured over here on the right. So that's a partial replacement on the right, where the socket is left alone and the stem and the ball are replaced. And then moving on to spine fracture. This, as I said, is typically a compression fracture, where one of the vertebrae is compressed, so it becomes shorter in height, and it can even become more wedge shaped, kind of a trapezoid as you see on the right there. An anterior, this is the front of the vertebrae that the arrow is pointing to. So you can imagine if you have one or more wedge shaped fractures like this, it's going to start to kind of angle the back forward into what we call kyphosis, or bending forward. So that is one kind of warning sign to look for, is if someone is having more and more forward bending through their back, it might be a sign that they're what we call anterior wedge compression fractures occurring. So those are some of the most common, bad things that can happen with osteoporosis. So certainly we would all be interested in preventing that. As with many things, the best treatment would be prevention. If we had a time machine, the best thing you could possibly do would be to increase your peak bone mass, which typically occurs between 25 to 30 years of age. And then after that point, it gradually decreases kind of throughout the rest of life. So physical activity, healthy nutrition, anything that increases that peak bone mass actually sets people up in a positive way to be less likely to have major issues with osteoporosis down the line. Unfortunately, unless we have the DeLorean, we can't exactly go back in time and change that at this point in time. So these are some of the risk factors to be aware of that are not modifiable. So we can't necessarily change our age. Females do have a higher risk for osteoporosis, higher rate of osteoporosis than males. And most of that is hormone related, primarily postmenopausal. The lack or the decrease in estrogen does affect the bone strength and structure. Anyone with a strong family history of osteoporosis is at a higher risk of developing osteoporosis. Any previous low energy fractures, so anyone who's had a hip fracture or a wrist fracture just falling from standing, or a compression fracture of the spine, has a much higher chance of having a subsequent low energy or fragility fracture. Certain medications, and there's certainly too many to name all of them, but glucocorticoid, steroid medications for prolonged periods definitely decrease bone mass. Some proton pump inhibitor, which are acid reflux medicines, certain diabetes medicines, immunosuppressant medications, certain blood thinners, many chemotherapy drugs, and certainly more medications do have a potential side effect of decreasing bone mass and putting a patient at risk for osteoporosis. And other diseases, rheumatoid arthritis, any GI gastrointestinal disease that affects nutrient absorption, decreases calcium or vitamin D absorption, can lead to osteoporosis. Kidney disease, HIV or AIDS, some cancers, eating disorders, many of those relate back to nutrition. So not a whole lot can be changed with those first set of risk factors, but these are some risk factors that are at least easier to modify. So a low BMI, which is a body mass index, so someone who's underweight, being at a normal, healthy, thin weight is a good thing, but being underweight or undernourished is a risk factor. Tobacco smoking or excessive alcohol intake is a risk factor. Poor nutrition and related to that can be vitamin D deficiency, eating disorders, lack of weight-bearing activity, or low dietary calcium, which is less common in America. We typically eat enough foods that contain calcium, that the calcium is not as often the problem as much as it is other nutrients and vitamin D. So warning signs to look for, as I briefly mentioned before, compression fractures certainly are one. If a patient or a loved one has increasing forward bending of the back, or kyphosis, or decreasing height. If you notice, that you're getting measured at the doctor's office and your height is decreasing, there are multiple things that could lead to that, but probably the most common is compression fractures or flattening out of the discs in the back. And each of those, contributes to a decrease in height. So if your height is changed by 4 centimeters or more, which is almost 2 inches, just a little bit shy, then that's certainly a concern to be evaluated for a potential compression fracture or other issues. So the way that we would typically do that evaluation is a DEXA scan, which is a dual energy X-ray absorptiometry scan, which is why we call it a DEXA scan. Doesn't take long, 10 to 20 minutes. I think probably some people have already been able to experience this, but most commonly looks at the areas of the lumbar spine and the hip or the proximal femur. There are other areas that can be targeted, especially if there's a concern in another area of the bones, but those are the most common areas. And from the findings of that scan, a score is calculated, and it's compared to 2 different groups. The T score is a comparison to what they call a young, healthy comparison, a young, healthy adult. And we look at how many standard deviations away from that control group patient's score comes in. And the Z score, on the other hand, is a comparison, basically a peer group comparison to an age-matched group of that particular patient's peers. So they're a little bit different, and primarily what's used for making a diagnosis of osteopenia or osteoporosis or ruling those out is the T score, because it's more of a standard comparison to the norm. So if the standard deviation is less than 1 or better, then that's considered normal. Between -1 to 2.5 standard deviations away from that normal score is considered osteopenia, which is, if you kind of think about pre-diabetes, it's kind of the similar situation for osteoporosis. It's along that same trending along that same route, but it's not all the way quite to osteoporosis. And then if that score is less than 2.5 standard deviations below that normal score, then that's considered osteoporosis. So depending on the score from that DEXA scan, as well as other risk factors and factors that are taken into consideration, patients can be kind of stratified. If patient's low risk or normal, then just a routine schedule of DEXA scan screening, general screening labs such as a chemistry panel or blood, complete blood count could be done on a regular basis, and preventive care, weight-bearing activities, nutrition, all those things we touched on. For someone who's considered at moderate risk, they may be recommended to make dietary changes, make activity changes, include calcium and vitamin D supplementation, or further evaluate those things to basically go forward with a non-pharmacologic treatment. And then in the third group of, if someone's deemed high risk, that's typically where a pharmacologic or medical treatment plan is developed. Within those osteoporosis medications, there's 2 main groups. One is anti-resorptive, which is basically trying to decrease the amount of bone that's being reabsorbed by the body, versus anabolic, which is encouraging more bone growth. So now we can kind of get into those medications and find out a little bit more about them. So just to kind of go back to the start, we mentioned that bone is alive. It's not just a structure that, like a support beam that's there and it's stagnant. It is constantly having small micro trauma. It's constantly turning over. Cells are being reabsorbed. Cells are being laid down. And so that constant process has to be at a good homeostasis or a good, steady state in order for the bone to function normally. So the idea of most osteoporosis medications is to target those processes to improve that bone density. So there will be a quiz on this particular slide at the end, so everyone needs to memorize the whole thing. And then you're halfway through orthopedic residency. But this is shamelessly stolen from the internet, but it does have a lot of information on it that can help to understand bone metabolism. So osteocytes are your bone cells. Just means osteo means bone, cyte means cell. Osteoblasts are the cells that are actually creating or encouraging the production of those bone cells. Osteoclasts are kind of the enemy of the osteoblasts. They are reabsorbing bone cells. They're breaking down bone. So in order to control those, you have many hormones and cytokines and all sorts of fancy body things that either encourage osteoblast activity or osteoblast production, or vice versa. So these are all of the different hormones and little cytokines and things inside the body that can be targeted by these medications in order to kind of turn the tide to improve bone density. And this is just another illustration of how bisphosphonates, which are one of the most common osteoporosis medications, work. So they are directly inhibiting those osteoclasts, which are, the osteoclast is moving along and trying to reabsorb the bone. The bisphosphonate is inhibiting that osteoclast, which is decreasing that bone reabsorption, which is meant to lead to increased bone formation, increased bone density. So this is a non-exhaustive list of anti-resorptive osteoporosis medications. There are some other indications for these medicines, but as you can see on the fifth column there, many of them are indicated for osteoporosis. So the top 7 are bisphosphonates. You can kind of see a pattern. They all end in dronate, so that they're a little easier to recognize. You may recognize some of these trade names or the brand names from commercials on the internet or on television or in the newspaper, but these are bisphosphonate or diphosphonate medications that are decreasing that osteoclast function in order to decrease bone reabsorption. Denosumab or Xgeva or Prolia is another common anti-resorptive medication that targets this rank ligand, which is right in this middle in the upper part of this illustration. Sorry. So the rank ligand is involved in encouraging osteoclast production. So if the rank ligand is inhibited, the osteoclast production decreases and the bone reabsorption decreases. So same end result, different pathway to get there. So looking at first at those bisphosphonates, like I said, they inhibit osteoclast activity. Depending on the medication, some of them are dosed weekly, orally, some of them are monthly. One of them is an IV yearly infusion, but they are sort of the mainstay for osteoporosis treatment. For 1,000 patients treated for 3 years with osteoporosis, it was calculated that 100 fractures would be prevented. So that's basically 1 in 10 patients not having a fracture over the course of just 3 years by treating 1,000 patients. So it's a pretty significant benefit. They do have metabolism by the kidney. So patients with a decreased kidney function are typically not ideal candidates for bisphosphonate therapy. In which case that denosumab, Xgeva, Prolia that we highlighted may be a better option. So it decreases that osteoclast production. It's an injection, 6-month duration of action, and the downside there is that it does have a risk of what's called a rebound fracture, meaning after that denosumab is stopped, there is a risk of the bone weakening and fracturing soon thereafter. So that's something to look out for. The adverse reactions are something that many people may have heard of. One that what became pretty widely talked about is osteonecrosis of the jaw, where some of the bone in the jaw or at the base of the teeth the bone can die. And unfortunately that resulted in a black or an announcement by the FDA in the early 2000s. And we'll touch on this a little bit later, but it's a pretty rare complication. Obviously it's a one that no one wants to occur to them or a loved one. But again, it's not a common thing that people should expect to encounter. 1 in 10,000 all the way down to 1 in 100,000. And then the other is atypical femur fractures, which is also not particularly common, but 50 out of 100,000 is not unheard of. And that one tends to be related to prolonged use more than 3 to 5 years without taking a quote unquote drug holiday or stopping it for a period of time. That is illustrated on this x-ray here. Patients begin with just a kind of what we call a beaking or bulging of the bone in that area, what we call the subtrochanteric place, location in the femur. And then that can progress to a full fracture without any significant trauma. And the theory is that prolonged use of the bisphosphonate can decrease the bone turnover in that area, and that's a high stress area of the bone, which typically undergoes quite a bit of bone turnover in order to repair any sort of micro traumas. But in the presence of the bisphosphonates for several years, inhibiting that bone turnover, it can weaken that area, which is counterintuitive, but it unfortunately happens from time to time. So not a common thing, and tends to occur if a patient is on it for a prolonged period, more than 3 to 5 years without any interruption. So at this point, most people recommend taking an antibiotic holiday for a year or two after being on it for that length of time. Transitioning from those anti-resorptive medications to the anabolic or building up more bone medications, there are 2 main ones in that category: teriparatide and abaloparatide, which are brand names are Forteo is teriparatide and Tymlos is the abaloparatide. The mechanism of action of these is parathyroid hormone receptor agonists. So they are basically increasing the calcium levels in the body to promote bone formation. So that's a normal function of the PTH receptor, and they are just kind of augmenting that in order to increase that bone formation. So it isn't a daily self-injection, so not quite as pleasant as just taking a weekly pill, but does function a little bit differently from those other medications. Again, with these, there is a risk of rapid bone loss after discontinuation. So it's common to actually start one of the anti-resorptive medications after stopping the teriparatide or abaloparatide. Teriparatide is a little bit older. Abaloparatide has just come out in the last 4 to 5 years. And the older version has not been shown to decrease rates of hip fractures, but it has been shown to decrease rates of all other osteoporotic fractures, whereas the abaloparatide or Tymlos actually has been shown to reduce the rate of those hip fractures. Just check the... So just to address a couple of these questions in the chat, they say yearly reclassed and Prolia every 6 months. Is there a limit on how long you can take, and can you switch between after 3 to 5 years? So to my understanding, and I have a disclaimer here in a minute on these, but to my understanding, switching between two within the same family would not really protect against those pathologic fracture risk. It has to be actually a break from taking a bisphosphonate in general. And yes, after a break from being on the medication, you can restart it at a future time, because the idea is that bone has had a period of time where it's able to kind of go through that normal turnover and healing process in order to kind of reset. So yeah, that segues very nicely into my disclaimer that typically it's not your orthopedic surgeon who is prescribing these medications. That would be primarily the endocrinologists or primary care physicians. There is some, monitoring of labs and duration and things that are better done by a primary care or an endocrinologist as opposed to a surgeon. But one of the major roles of the orthopedic surgeon in this process is that risk factor that if a patient does have a fragility fracture or breaks a wrist, breaks a hip, something along those lines, that is a key time to be recognizing that and getting this process of identification of the osteoporosis and initiation of whatever treatment is most appropriate. So I think my answers to those questions are accurate, but they would also be good questions for your primary care doctor. So looking at, as I mentioned, kind of identifying patients who are at risk and getting that process started. Over the years, we have not been great at this in America or in the world. So a study in 2004 showed that only 15% of patients were prescribed a bisphosphonate within 6 months after a hip fracture. So basically, 7 out of 8 or 6 out of 7 patients were not getting started on that medication that could potentially prevent a subsequent fragility fracture. That number actually got even worse because of some of these safety announcements that came from the FDA as the medications were, studied, and some of these adverse side effects, such as the subtrochanteric fracture, as those things were identified, these safety announcements came out, and prescribers and the general public kind of became a little bit more wary of these medications. So that number actually dipped all the way down to 3% of patients being prescribed a bisphosphonate after hip fracture in 2013. So I think it was a bit of an overcorrection. They're very beneficial medications. As with almost any medication, they do have, there's a safe way of prescribing, and there are guardrails that need to be used. But there's also a chance of adverse reactions that does not, in this case, outweigh the benefit. So Own the Bone continues to be a program within the orthopedic community, basically of acknowledging that even though orthopedic surgeons are not the primary prescribers of these medications, or not primarily the ones that are either performing a DEXA scan or even often ordering it, it's our duty to our patients to initiate this process and to be constantly on the lookout for osteoporosis and communicating that with patients. Again, so based on other studies, 80% of patients with fragility fractures not receiving the recommended osteoporosis care. And those patients are 86% more likely to have a subsequent fracture than someone who hasn't had a fragility fracture. So this has been a concerted effort within the orthopedic community to improve those rates and to help avoid subsequent fractures or secondary fractures for patients who do have osteoporosis. And it definitely has been shown that programs oriented to improve this can be successful. They're typically often called fracture liaison services or a fragility fracture program, in order to identify at-risk patients, initiate those screening processes, and then initiate those appropriate treatments. There was a program in Scotland that was able to improve the rate of evaluation from starting at less than 10% of patients to nearly 100%. And then Kaiser Permanente, the huge medical conglomerate in California, began their program in 2002, and by 2006 had a 37% reduction in hip fracture versus the expected rate of fractures at that time. So it can have a major effect, having processes and programs in place in order to make sure patients get the appropriate screening and the appropriate treatment. So just to kind of circle back to some take-home points for the audience here today. How can you optimize your bone health? Healthy diet, calcium, protein, leafy green vegetables, vitamin D. Ideally, you can get all of the vitamin D that you actually need from the sun. That can be harder in the winter. A, there's not as much vitamin D getting through, and B, it's cold and dreary outside. But 15 minutes per day can get you the vitamin D that you need. From a diet and nutrition standpoint, fish, eggs, mushrooms, vitamin D fortified foods such as vitamin D milk or cereals also have that vitamin D that can get you there. Maintaining a healthy body weight, which goes both ways, neither too heavy or too underweight, and then weight bearing or resistance physical activity. My formatting got a little off between two different computers here, but walking, even just light weightlifting or resistance activity, aerobics, anything like that helps to not only strengthen the muscles, but also strengthens the bones. I'm getting there. Just as an aside, we actually see the opposite with astronauts. I just saw an astronaut just came back from the space station after like a year. That they will certainly have osteoporosis at this point, just because there's not weight bearing or resistance activity in space. So kind of fun fact. And then avoidance of smoking, excessive drinking, that can be risk factors. The Osteoporosis Foundation does have a site where you can actually do a little questionnaire and check your own risk as a an initial home screen, and that is just riskcheck.osteoporosis.foundation, and you can click through that and get some information at home. And then just general screening criteria. Men over age 70 and women over age 65 should be talking to their doctors about bone density testing. And then anyone age 50 and up that has certain risk factors, prolonged steroid use, smoking, any previous low energy fracture, low body weight, any of those medications or medical conditions that we listed previously, and an age of 50 plus is typically an indication for a DEXA scan. All right, so that wraps it up, and not sure if there were any additional questions on the chat.
I have one. I'll just ask you if you want to. I don't know if you want to unshare your screen, but I was wondering. I know you talked a lot about fractures, and I'm thinking there might be a lot of people in the room who could right now be thinking they might need a knee or a hip replaced just based on normal wear and tear or arthritis or what have you. So I'm just wondering what your criteria is. I think in my opinion, my husband put his off for way too long, and it's major surgery, and I completely understand why, but what are the kinds of things we should be looking for if that hip or knee just isn't getting any better, and in fact it's getting worse? Do you have criteria to share? And is it bad to procrastinate a replacement surgery like that?
So it certainly can be, it can be bad to procrastinate too long, if for no other reason than it's kind of prolonging that pain and suffering. Sometimes you can have loss of motion or strength or activities along the way that could have been avoidable. I will say osteoporosis and osteoarthritis are, even though they're tend to run in the same age groups, they're separate processes. So if you have osteoarthritis, doesn't mean that you also have osteoporosis or weak bones. It just means that certain joints have worn out. But typically, if you have pain with activities, any decreased range of motion or stiffness, typically the first line treatments are just your over-the-counter Tylenol or anti-inflammatories. But if you're doing that and it's really not cutting it, you're not able to enjoy your activities or not able to do everything that you need to do, then it's probably time to at least have a discussion of what's an option and what could be done.
Okay, C. Wilkins is raising her hand, and I'm going to unmute or ask you to unmute, and you can go ahead and ask your question if you'd like.
Thank you. While you do, I'm going to reshare my screen so I can pull back up the risk check site.
Okay. Yeah, great. Thank you.
Thank
Go
you.
ahead.
Thank you so much. I have kind of a unique situation. I'm sure it's not unique for everybody, but I am very overweight, and I have bone-on-bone knees and have had them for several years now. I've had them looked at several different times, and I've been told that I am not able to have any kind of knee surgery done. I'm understanding I'll have to have total knee replacement. And I'm told that I will not be able to have anything done until I lose a large amount of weight. So this is sort of a roundy round thing. My exercising is part of losing weight. I'm not able to exercise much because I'm hobbling around like a 1-year-old. I'm in pain every single day. I don't take anything for it. I just deal with it. But my question to you is, I'm working, my food intake is better, but the exercise is very difficult because of the knees. So it is kind of a roundy round situation. And would I benefit at all by some sort of maybe physical therapy or something like that as the progress, as the weight continues to go down? And how much do I need to go down to be able to have the knee surgery that I need so badly?
Mhm. So I think you kind of touched on it at the beginning, but it is a specific situation, but is by no means uncommon. We have this discussion basically every day because it's a really difficult situation to navigate. As you said, the diet, portion, nutrition, half of that equation. Everybody knows diet and exercise, and exercise is much harder when everything hurts. So the diet portion becomes all the more important, which you mentioned already, working on that. Physical therapy can be very helpful, and specifically pool therapy, or whether it's therapy or water aerobics, or even just walking laps in a pool. The buoyancy of the water tends to take a lot of the pressure off of the painful joints, and it also gives some resistance. So walking, you're having to really burn more calories and fire the muscles harder in order to move. So aquatic therapy or pool exercise tends to be very helpful in that situation. There's another resource that has fairly recently become available within LMH that the pharmacists have started, which is a weight loss consultation that they can do, just for very similar situations as what you described, in that there are some medications that have actually been shown to help with weight loss in addition to diet and exercise. And so what they can do is they can talk to you, look through your medication list, look through your, medical history, and evaluate whether there are any medications that might be advisable to add in order to kind of help you along the way with the weight loss journey. And so that would be, I don't know if there's an email list, but maybe that would be a resource that could be disseminated. But that's been something that patients have found very helpful. In extreme situations, weight loss surgery is an option for some people and can be effective for some people. It's certainly not an option, or not the best choice for everyone. And then I think the one other aspect that you asked is what we look at for knee replacement or hip replacement surgery is the body mass index, which is a calculation of between height and weight, which is easiest to look it up online and plug in your height, plug in your weight, because it's centimeters and squared and dividing, and it's a lot of math. But the border between what's considered obesity and severe obesity is at 40 on that calculation. And that number has also been found in the orthopedic community. Above that number, the risks of infection and wound healing problems and loosening and many things like that is much higher beyond that number. So that number of 40 BMI is where that cutoff is for having a knee replacement. And that's why it's not by any means a punitive or trying to be mean, but it's just to avoid as many of those complications as we can.
And we will follow up with some links, especially when this program gets posted. So we will send that out to everybody. So we'll try to get that information to you. There are several questions in the chat. We always want to honor the doctor's time. So I will kind of take them in order. Well, so the doctor just did post the risk checklist site again. So thank you for that. Some of these, again, are, personal questions that your own doctor could answer. This is a pretty general one, but can you talk a little about arthritis and rheumatism?
Yes, and I would say I would include family history in probably one of those. I would ask your personal doctor, but that could also be grouped into one of those categories for higher risk. So arthritis is kind of more of a generic term to describe joint degeneration or joint wear. It can be osteoarthritis, it can be inflammatory arthritis, it can be rheumatoid arthritis, which rheumatoid arthritis is a subcategory of inflammatory arthritis. It's more of an inflammatory, or the body is actually kind of attacking itself and causing damage to the joint. So there's a whole different subset of medications for that are called DMARDs, or disease-modifying anti-rheumatic drugs, that have really revolutionized rheumatoid arthritis and have decreased the really severe joint problems that rheumatoid arthritis can cause. So that has really changed a lot of things in the world of orthopedic surgery, because you used to have young 40-year-old people with just absolutely crippling hand deformities and constant pain, where those medications have not completely eliminated that, but really made an impact there.
Let's just skip real quick down to the how long of a drug holiday away from the bisphosphonates in your recommendation?
Yeah, I wish I had a more certain answer on that. Off the top of my head, I want to say it's a couple years, but again, it's not a drug that it's not a class of drugs that I'm actively prescribing on a day-to-day basis. So I don't want to lead you astray with that. If you have a internal medicine or family medicine primary care physician, they would certainly be a good resource for that. So I don't want to lead you astray on that one.
Okay, and then do you want to address the costs? There's a question: which drugs are the most and least expensive? That probably is a moving target.
Probably depends somewhat on your insurance, and so it would be something I couldn't really speculate on. Probably varies from person to person, but again, something if you're in that situation, your doctor decides that that's appropriate treatment, hopefully they could find one that fits both medically and financially.
Okay, and I'm going to take this last one, everybody. Regarding risk of rebound fractures after discontinuing the meds, do you have percentages of likelihood?
No, sorry.
Okay, fair enough.
Yeah, not off the top of my head. I don't know an exact percentage.
Okay.
I do know that they can sort of offset that risk by following one class of medication with another in order to kind of offset the effects, but I don't have a specific percent.
Okay. Oh, I did see one more. I think this will be a shorty. Should you always take, should we be taking, a lot of us do take vitamin D, and here's a person who does, but should you take calcium with that? I mean, if you have just a little bit of osteopenia, or
yeah, as much dairy as most Americans have in our diet, most people don't really need calcium supplementation. There's always exceptions, but calcium is less essential as far as taking a supplement than the vitamin D for most people.
Okay. Well, let's call it there so that you can get away and enjoy that Doctor's Day party. I'm sure you're going to. Thank you so much for your time and for that presentation. I know everybody learned a lot. We're getting some kudos in the chat. So we appreciate you, and good job.
Yeah.
Thank you,
so
guys.
much.
Thanks
Thank
for
you.
coming out.
Thank you.
Okay.